Hey, this is Dr. Ben Pearl with FitFootU. So I was discussing with my patient advocate colleague, Craig Thomson, the conundrum that we face with healthcare right now. It's kind of a maze, isn't it, Craig?
It really is.
And, we were talking and we were trying to say, how could we express this visually, almost like Sesame Street? And you came up with a Venn diagram. And then it was like two mad scientists. I said, well, yeah, we could do that, but what about the silos and doing farm silos of the disconnect between the providers? So without further ado, Craig, you're going to lead it out from a patient perspective of where we sit in 2025 with, the myriad of healthcare options and the confusion.
So, Dr. Pearl, in one such example, we have a patient that's presenting before the PCP with some type of a muscular problem. We don't know if it's tendinopathy, a ligament, a strain.
And he's the gatekeeper, Craig.
Yeah, so the PCP is right there at the top of the food chain, or the initial point of entry.
Okay.
This is the initial source where the referrals start to begin.
So the patient, let's say the patient has a muscle weakness, and then what happens, Craig?
So the PCP is then kind of in a bit of a conundrum at this point, and he's got to make a referral. Now, he's got all these different optionalities that he can refer to. He'll start with a conservative modality first. Once he's exhausted that, the referrals will start, and that's where we get into all of these siloed, compartmentalized, and hyper-specialized areas that don't really communicate and talk to each other.
There is a little bit of overlap I saw on some of this, but sometimes in the initial triage, let's say he sends to his buddy an orthopedic surgeon because he thinks he's got just weakness in the joints or a joint that's inhibiting him. But then after that, orthopedic says, this isn't the problem, it's more muscular, then it's more neuromuscular, then what typically happens with the PCP, Craig? What would be, give me a scenario.
So at this point, we've now got referrals within referrals, and we're now getting referred to subspecialties within other specialties. And so maybe he's actually gone to pain management as well, and he's gone to sports medicine.
Okay.
Perhaps he's done physical therapy. Perhaps he's gotten some non-operative injections because the orthopedist said, you know what, this is not a candidate for surgery. And then that led to the more testing, the path labs.
And by the way, you had yourself a situation where you went to pain management, and I think it was on your fibular notch of around the knee, around the nerve area there.
That's
yeah.
right. So I was diagnosed with peroneal neuropathy of the lower left leg. Now the response from orthopedic surgery was, let's go ahead and do nerve decompression surgery on this. But I went back to neurology and I said, what do you think about this? And he said, you know what? These guys are sometimes like a carpenter with a hammer and a nail. That's the only thing they see.
Yeah.
He said, don't do it. I said, why not? You'll come out of it with a neuroma. And so then what happened is I went to orthopedic sports medicine, regenerative, and they said, hey, you know what? These guys never mentioned to you hydrodissection. What's that? It's a 5% dextrose sugar water injection injected 3 times over 3 consecutive months at the fibular head, which then allows the nerve decompression to resolve itself.
And in this algorithm, where did you end up going for that?
So that actually ended up me going over to a regenerative sports medicine specialist who was non-operative, because the operative guy wanted to open up with a knife right away.
But funny, we can also see that from a pain management, because they do those hydrodissections as well.
Yeah, they do it as well. And a lot of them actually have formerly and previously been in anesthesia. And then they kind of realized kind of a market opening. They decided, and they migrated over to pain management.
Now, we were talking before too, Craig. Let's say another scenario that's a little bit more complicated. The muscle pain isn't going away. There's been some overlap of the general neurologist, let's say, but talk to me about the silo aspect, and you had an analogy of with medicine, how that silo also plays out.
Right, so we've got cases where somebody is sent for a workup to neurology.
And then would they see maybe a siloed subspecialist?
And that could be a referral at that point that goes to neuroimmunology or to a neuromuscular specialist, where the neurologist at a certain point, because of a negative EMG or a negative nerve conduction study, says, I don't know what to tell you. Now that,
Now, what's the reaction for you as a patient when you hear that?
the patient is actually very frustrated.
Were
at
you
this
frustrated
point.
when you had those kind of?
I was quite frustrated, and at one point I actually posed the question. I said, "Who connects the dots here?" And the subspecialty said, "You do that." I said, "Okay, listen. If I'm the one who connects the dots, that means I'm going to be diagnosing myself. We're getting into diagnostics. Who's the diagnostician?"
But you had another analogy. You said so sometimes even amongst the subspecialties, it gets very granular. They're so focused on what they do. So talk to me about the silo analogy here, Craig.
Yeah, so in this case, this is actually similar to the civil service and the government and various government agencies and even units within one particular agency that don't talk to each other.
And you
they-
represented that in your not off the Venn, but in the silos that you constructed. So talk to me.
Right. So you would think that there's overlapping knowledge between and amongst the siloed subspecialty
Who has
practices.
been referred by the PCP.
and
Yeah.
then later referred by a neurologist, and then the neurologist makes these further referrals here.
So we got neuroimmunology, neuromuscular, and then neurosurgery as options.
Right, and that's all coming from a non-operative standpoint where the neurologist made the referrals, and so yeah.
Yeah, and you made the quip that you hope what doesn't happen on the tertiary, worst case scenario.
Well,
That we go straight to the bluff, right?
Yeah,
Yeah,
and-
show us. yeah.
and we don't want to end up like lemmings being led off of a cliff and
Right,
then ending
right,
up,
off the bluff.
and then ending up in an oceanic river or a creek below.
Yeah, I think that's where your chutes and ladders comes in as well. And at any one of these points, if you don't have good communication amongst them, or if you can't get a referral, it's kind of like rip.
Right. And this is where we actually have seen within behavioral health, as another example, there's a clinical psychologist that serves as a diagnostician. There's a referral made to psychiatry, which is strictly medication management. Then there are clinicians that will deal with what they call emotional dysregulation, but only that. And then the ultimate source usually is some form of a cognitive distortion or cognitive dysregulation. That circles back to
Sounds like a mess, Craig. It's a tough spot we're here in with the healthcare model. But I think if you are prepared to know that these are some of the booby traps in the system, you'll be a little bit more, I think, prepared to address these questions at the time of the visit and know when maybe you want to bypass or be proactive for yourself to try to bypass some of these steps.
Especially when you want to look at the bigger picture, and if you find that certain people are getting lost in the weeds and they cannot see the forest for the trees, you definitely want to have the biggest possible holistic macro picture so you can understand where people are telling you or they don't show any intersectionality, there is some intersectionality.
I love it. Do your due diligence. There are healthcare advocates out there. You can call different organizations for help. Certainly don't always just refer to Dr. Google. That can be down its own rabbit hole. Try to find good community groups, good community support groups, and then test the waters too amongst your family network, friend network, with which physicians are going to be most practical for your individual situation. Till next time, this is Dr. Ben Pearl with Craig Thomson with FitFoot U.